afternoon. It's great to be here. It's great to see hepatitis C on this program, to have an opportunity to actually begin to talk about hepatitis C prevention in the context of a test and treat era. Because I'm really here today to talk about the dawn of a highly effective all-oral therapeutic regimens for hepatitis C, which really represent cures. And as being a 14-year veteran of the HIV/AIDS program at CDC, I think that's welcome news whenever you actually have, for the first time perhaps, have a cure for a chronic viral infection. We have a formidable task ahead of us to try to see how do we bring those curative treatments together with the populations, but the opportunities for a payoff for public health is immense. Because we have a large burden of disease for hepatitis C globally. Just recently, this week actually, revised estimates place the number of persons living with chronic hepatitis C at 185 million around the globe, contributing to almost 500,000 deaths per year. In the United States, based on NHANES, our health survey, approximately 3 million persons are living with hepatitis C, and about 16,000 deaths are associated with that infection on an annual basis. As we reported last year in the Annals of Internal Medicine, the mortality from hepatitis C is on the rise. Indeed, we're in the midst of an epidemic of hepatitis C-associated morbidity and mortality in the United States. In this analysis, we described a 50% increase in mortality over a 8-year period, to the point where in 2007, the number of deaths associated with hepatitis C surpassed the number of deaths from HIV, and that disparity only widened with an additional year of data for 2008. Not by any means, obviously not in this crowd, to say that HIV is no longer important, but just to show how that decline in HIV represents a collective action of clinicians, policymakers, public health, and others, and shows what you can do when you bring all those resources together. And we really need to begin to assemble that type of capacity for hepatitis C to have a similar impact on this mortality curve. Unfortunately, our health models estimate that this morbidity and mortality from hepatitis C is expected to continue into the near future. This was a Markov model that we published several years ago, estimating that almost 1.5 million persons will develop cirrhosis over the course of their lifetime, and about 900,000, or about 37% of all persons currently living with hepatitis C will die of an hepatitis C-related complication. So that's our challenge. That's their curve. Are we going to let that curve happen, or are we going to seek to reduce it? Now, this epidemic of morbidity and mortality now is a reflection of an epidemic of incidence in earlier years, particularly before the virus was discovered in 1989, when injection drug use was particularly prevalent, and transmissions were ongoing in the healthcare setting through blood transfusions that were not screened and through unsafe injection practices. As the virus was identified, antibody tests developed, the blood supply became much safer. Prevention strategies, mainly those targeting HIV prevention, had an impact on preventing transmission of hepatitis C virus among injection drug users, but just not to the same degree, with prevalence remaining still quite high among IDUs relative to the dramatic declines of HIV among this population. So as you can see there, the incidence has fallen quite large, but we can't be complacent, because indeed we saw incidence, after many years of it remaining level, we saw the incidence go up for the first time this past year. And it reflects an increasing phenomenon that we are seeing in a progressive number of states in the United States, with increases in case reports of hepatitis C among adolescents and younger adults. And this is what Ron alluded to. Started in Massachusetts, progressed into New York, the Great Lakes area of Wisconsin, for example, and Ohio, and now up and down the Appalachian chain of Tennessee, West Virginia, North Carolina, and other states. And these counties that are shaded in blue are those that are reporting increases. And based on our limited epidemiologic data at this point, it really seems to be young persons in suburban, exurban, and rural areas progressing from narcotic use, oral narcotic, Oxycontin use into heroin injection. Much different from the early years of the HIV epidemic that tended to be an inner city minority phenomenon. This is tends to be in less populated areas of the country among white adolescents and young adults. So something we definitely need to get a handle on. Now, the reason we're here today is because we do have curative therapies. We've had curative therapies for a number of years, and the collective data looking at those show that they do have an impact in clearing virus, which in the parlance of hepatitis C is known as sustained virologic response, or an SVR. And studies have shown that that reduces the risk of hepatocellular carcinoma by about 70%, and the reduction in all-cause mortality of about 50%. Now, and the success of these therapies has improved over time. They tend to be, right now, based on pegylated interferon. Ribavirin is the standard treatment. In 2011, the addition of the first direct-acting agents that that could act against the replication cycle of HCV were licensed. When those were added, it increased the chance of viral clearance. And now we have a very robust pipeline of at least 22 agents in phase 2, phase 3 clinical trials that promise even higher and more successful, higher SVR and more successful outcomes. Now, if we continue to be on the agenda for this meeting, I'll have to ask Julio to not have it while EASL is going on. EASL is the European Association for the Study of the Liver. It's one of the two large meetings that releases data about these types of clinical trials. And I just wanted to give you several examples of the data being presented at that conference, showing regimens of only 12 weeks in duration, one QD or BID dosing, 2 to 4 pills per day, depending on whether persons are treatment naive or have been previously exposed to pegylated interferon ribavirin, having sustained virologic response or viral clearance ranging from 50% to over 90%, with an excellent safety profile with very few adverse events in this group. The asterisk, is, as you can see there, is for sofosbuvir, which is a polymerase inhibitor, and when you combine that with ribavirin, you get the SVR shown there. That's been submitted to the FDA as a new drug application for genotype 2 and genotype 3, and that's if this typical timeline holds true, then you can expect this regimen to be available for everyday use in the United States by the fall of this year. Abbott is expected to be in 2014 and BMS in sometime thereafter. Given the increasing morbidity and mortality from hepatitis C and the increasing opportunities to cure infection and reduce the adverse health consequences, we wanted to go beyond our standard risk-based approaches to identify this highly prevalent population progressing through time at increasing risk for HCV morbidity and mortality. So we moved toward a birth cohort approach to testing using a grade-based evaluation process for the data, identifying and recognizing that this population, almost over 3% of them had been infected with hepatitis C, representing a prevalence 5-fold greater than other ages of persons in America. About half of those, based on NHANES data, did not report a transmission risk, either because they were reluctant to do so or didn't recall it or didn't truly know it. This intervention, we estimate, could identify an additional 800,000 persons currently aware of their status, and when linked to care and treatment, could avert 121,000 deaths using the current 3-drug regimen at a very favorable cost per quality of $35,000 Now, the ultimate impact we can have on that mortality curve that I showed you earlier is really going to be how successful are we going to be in identifying these individuals and linking them into care. And estimating if you treat 15%, 25%, 50%, 75%, you can have a progressively greater impact on the number of deaths averted. So the policy is one thing. It's well supported by data, but the implementation is now the key for us to have this impact on reducing mortality associated with hepatitis C. The other promising aspect with safe, very tolerable, short-acting, highly effective therapy, you begin to really truly talk about treatment as prevention of new infections. This is just one model that Mel is going to spend more time on, just demonstrating the impact on the prevalence among injection drug users with relatively modest uptake of treatment. Relatively small numbers of persons treated with a very modest SVR estimation. Given what's the prevalence that you begin with, you can have a large impact down the road. And that's what this model shows. And we'll see some data for Vancouver specifically here in a moment. Unfortunately, our test, care, and treat cascade is even worse than what we've been seeing at this meeting for HIV. This is based on a observational cohort study that we do of looking at over 12,000 persons in care for hepatitis C, known as CHECS, and looking also at the NHANES data that Ron mentioned. Bringing those data together, we estimate that only about 50% of persons infected with hepatitis C have been tested and found to be infected. Only about 37% of those persons have been referred for care. A smaller proportion have even been tested for viremia, which is a necessary step for them to be accessing treatment. About 14% have been placed on treatment, and about 7% have achieved an SVR. So we have a ways to go on all steps of this process. And this poor treatment cascade is a reflection of multiple barriers, beginning at the patient level, reflecting variable access to the healthcare system, as Ron pointed out, competing health priorities such as comorbidities or mental health issues that can sometimes be barriers to care, stability factors, particularly among injection drug users regarding employment and housing, and just a general lack of knowledge, as the Institute of Medicine highlighted in their report on hepatitis that they released in 2010. At the provider level, again, an inadequate workforce with the knowledge and the skills to test, manage, and treat persons with hepatitis C, both at the primary care level and also at the specialist level. Which at this point, the specialists tend to be fairly limited to the hepatologists, which is a very small group of providers, with the gastroenterologists being fairly disinterested in hepatitis C care, and the infectious disease group beginning to take a renewed and new interest in care, but at this point limited for the most part to co-infection. And then structural systems, the lack of care models that are widely disseminated, reimbursement for HCV care. Treatment costs can be quite considerable, ranging from $50,000 to $70,000 for a course of treatment, and the workforce issues that I've already identified. So all of those impact those various stages of this cascade. Now these new oral treatments can have an impact on some of these. Because if you look at the data about why people don't get treated, a lot of it's worried on the patient level, worried about side effects, worried about time off from work, disability. When you have a safe and tolerable regimen, some of that will go away. On the provider side, similarly, complexity of treatment is an issue. Again, that will go away. So the new therapies do represent real opportunities to improve capacity and remove some of these barriers. We also have done quite a bit of work on developing national plans that really lay out what needs to be done. In policy development, of which I've given you an example, ways of expanding access to testing, care, and treatment in a reformed health system that's emerging because of the Affordable Care Act, how we can build capacity through integration, partnership, simplifying care recommendations, targeting marginalized populations such as corrections, for example, and how we need to change our surveillance to monitor outcomes, targeting not just tracking burden, but also tracking the assurance that persons are receiving these services and tracking those different elements of the care continuum. The other thing we have to be mindful of is we have to be realistic that the investment in hepatitis C is low. And even though we have a large burden, we have rising morbidity and mortality, we have a population, most of whom are unaware of their status, and even fewer in care and treatment. The dollars limit us, frankly, from doing all we can at this critical time in this epidemic of HCV morbidity and mortality. So I hope I conveyed that the burden of hepatitis C-related disease is large and growing, that many, if not most persons living with hepatitis C are undiagnosed. These new treatments do represent a tremendous opportunity to reduce morbidity and mortality. And if I'm thinking about treatment as prevention, we can prevent mortality by getting people living with this infection into care promptly. We need a research base to guide HCV treatment as prevention framework. We have some good models. We'll be hearing more about that in a moment, but we really need to beginning to get some real life data about how to apply these treatments and what's their impact on interrupting transmission. And through all of this, to be successful in preventing mortality and preventing infection, we're going to have to do all we can to increase the capacity for testing and care and treatment to realize these health gains anticipated from the new therapies. I want to thank those listed here for helping me with this presentation, and look forward to the questions. Thank you very much.